I'm Art Fleischer, Chief of Ultrasound at Vanderbilt University Medical Center, Nashville, Tennessee. This presentation, I will cover what the new developments are in the early detection of ovarian cancer with sonography. This presentation will cover the new developments in the detection of ovarian cancer with sonography. I have no potential conflicts of interest. The objectives here are to present the principles and the concepts concerning early detection of ovarian cancer with sonography, discuss and illustrate the application of 2D ultrasound, 3D transvaginal color, 3D morphology, and I will mention contrasted transvaginal ultrasound. Please note that at present the microbubble applications for non-cardiac uses are not available through the FDA, but that these microbubbles can be used off-label as investigational review boards approve in different areas. This data is basically generated from an R21 grant through the NIH, National Institutes of Health, the National Cancer Institute. I'm grateful to AIUM for providing grants for the early development of microbubbles and testing in preclinical models. I'm also appreciative of Definity and Bracco, and in the early stages, Shearing for support for investigations using microbubbles. Again, microbubble contrast is not currently approved by the FDA for non-cardiac general applications, but we hope to have this approval very shortly. This country is the only country in the world that has this constraint. Microbubbles can be used as off-label in academic medical centers. Personal disclosures, I have really none. I must say that sometimes I'm a bit spacey, but I want to thank Dr. Beryl Benassaraf for her permission in using some of the 3D images, and also acknowledge Philips for their help with some of the images in CineLoops. I want to dedicate this to Gilda Radner, who unfortunately passed away many years ago now for complications of ovarian cancer. Being a comedian, she made the best of it, and if anyone wants to hear the personal side of ovarian cancer, I suggest listening to her audio tape, It's Always Something, which was recorded just a month before her passing. I also want to mention that it's her impetus and her husband, Gene Wilder, who is an actor, to set up these Gilda clubs, and we have one in Nashville, and they're basically areas for people that have family members, loved ones affected by cancer to come and feel communality with each other. Okay, with ultrasound, we're able to see cancers of the ovary. We're able to differentiate benign from malignant and hemorrhagic lesions, and we can look at flow with microbubbles, and whether or not this is a screening modality really needs further evaluation. It would be great to identify patients that are at risk with some type of drug or lab value. The CA-125 or the proteomics tests have been proposed, and these are ways of identifying people at high risk who should undergo screening with ultrasound for early detection. Okay, as a general comment, color Doppler allows us to look at parameters beyond morphology, and in the past several years, we found that color Doppler is essential in finding early ovarian cancer. In a practical sense, we can differentiate benign from malignant masses. In other words, evaluate patients that could be just observed versus patients that need referral to a gynecologic oncologist. And I will not talk about torsion, but color Doppler is essential in evaluating patients with torsion. So color Doppler over the years has gone through an era of what I call inappropriate enthusiasm, just like any new modality. When it comes out, it's 95% accurate, great. And then there's a period between the first papers and reviews of healthy skepticism, and then reality. And I say there's optimists and pessimists, and basically color Doppler is helpful in evaluating patients with adnexal masses. I'm going to briefly mention the role of color Doppler in evaluating patients with pelvic masses, and to do that we need to really understand what color Doppler is telling us. Color Doppler is very important in determining the relative blood flow and the relative impedance in the soft tissue structures that we're seeing. It's very angle dependent. So color Doppler is highly dependent on what the interstitial pressure is inside of masses and tumors. Some masses have very high interstitial pressure, such as tumors, and their color Doppler signal will reflect that. Some masses have lots of vasoconstriction, and the Doppler signal will also reflect that. In early days, we thought that we could differentiate benign from malignant based on the vessel structure, where a normal vessel, as shown at the top, has a muscular media, and there would be a big difference between systolic and diastolic velocities. In the bottom, we see examples of a vessel within a tumor that has little or no muscular media. It has high diastolic flow due to AV connections, and in the middle there's a waveform obtained from a normal vessel that is vasodilated. Basically, the Doppler waveform can be evaluated and quantitated using systolic to diastolic ratio, resistive index, pulsatility index, or we can look at the area under the curve, which is basically a reflection of the number of vessels of blood cells going by at a particular time. And as opposed to frequency-based Doppler, the power of the signal, or the amplitude of the signal, allows us to see smaller blood vessels. And there's advantages of amplitude or power color Doppler. The advantages is we can see flow at very low flow rates. There's no aliasing, and the disadvantage, however, it's very susceptible to motion artifacts, and originally Doppler direction could not be determined. This is a nice side-by-side example of a hemorrhagic luteal cyst. On the left we have a frequency-based image, and on the right we have power Doppler. Power Doppler shows blood flow in the wall of the lesion. This is a patient that has a solid mass, and we can see with a power Doppler signal a larger vessel group around the periphery of this lesion that is, although it's solid, it is benign. There's no central vascularity. When we did an H&E assessment, you could see perhaps some of the vascular structures, but this is much better shown with a vascular staining, that the power Doppler was showing the peripheral vessels in this point, in this patient, was a hemorrhagic corpus luteum. Now, the vessel arrangements in benign versus malignant lesions potentially could be of interest. Here we have a reconstructed 3D image from original work done in the 90s, where normal vessels were reconstructed. You could see that there's a very definite pattern of branching, and histologically you could see the vessels have the muscular media surrounding the lumen. Now, in your mind, differentiate that from this group of vessels shown in a tumor. There's arteriovenous shunts. The vessels are clustered, and the vessel histologically does not have the muscular media that we've been talking about. So this brings to point the understanding of neoangiogenesis. This is a normal phenomenon in corpus luteum formation, in developing placenta and wound healing, but these processes are regulated. Tumors, unfortunately, are not regulated, and the angiogenesis is quite different. And Dr. Judah Folkman came up with this idea in the 70s that in order for a tumor to grow from a few millimeters, it needs to incite this blood supply. The blood supply is a very abnormal bunch of vessels, and early on, there's areas of relative ischemia in the center of the tumor. This is a scanning electron micrograph of a small breast tumor, a few millimeters, and you can see these abnormal vessels. It does this by production of what's called vasogenic endothelial growth factor, VEGF, and we can see in the tumors that they have different patterns, that early on there's a rim of vascularity, which later develops into focal areas of ischemia. How does this relate to color Doppler? Well, color Doppler, when we initially evaluated it, was thought to be representative of changes in the RI or the PI, but we needed to know where those vessels were. We think that vessel density and arrangement is important in morphologically abnormal areas, and less important is the actual number and the absolute velocities. So 3D now allows us to look at vessel branching, and I'll show you some examples of that. So basically, color Doppler is looking at the physiology, the process of follicular development in a person of childbearing age. For example, where there's a corpus luteum, there's lots of smaller vessels. And in areas where there's no follicular development, the vessels are very tortuous, very different in their impedance patterns. So this is an example of a mature follicle and the blood flow along the periphery. There's a focal areas of ischemia where ovulation will occur. This is an example of a functioning corpus luteum where the Doppler signal shows low impedance values. This is a power Doppler image of another patient's ovary showing the smaller vessels and showing the blood flow in these vessels. This is an image from Dr. Anna Parsons, who showed very nicely with power Doppler the rim of vascularity in a normal corpus luteum. So getting back to the idea that we could differentiate benign versus malignant, there was some work done by the early pioneers in this area, which said it was 99% accurate. Of course, with further evaluation, and our group showed about 80% accurate, depending on the values that we chose to be our cutoff points. And we used a pulsatility index in our original work. We also extend that to looking at whether the vessels are central or peripheral, whether they're low or high impedance, and where you can see the vessel and determine in a range gate what the actual values is. And we also looked at whether or not there was a notch. Well, this got to be very complicated, and coming to whatever the absolute truth was kind of a difficult task using all these numbers. So basically, looking back at the morphologic aspects, these two are Homo sapiens, and there's definitely different morphologies. Morphology is basically the study of shapes, and benign lesions have thin-walled septi, have thin fibrin strands, internal interfaces, and are usually unilocular. Suspicious lesions have papillary excrescences, thick walls, or mural nodules. Now, these are a series of images showing where 3D is very helpful in finding these morphologic pictures. 3D can be performed as shown in numerous studies with transvaginal probes. And this is a nice example from Dr. Benacerraf's work of a septum beautifully shown to be simple in a benign septated cyst. This is an example of the thin fibrin strands seen in a hemorrhagic lesions versus the thicker septation seen, in fact, in this hemorrhagic lesion. This is a 3D depiction by Dr. Benacerraf's group of a dermoid cyst showing the abnormal internal morphology. And this is probably the most important image you can have, and that is of papillary excrescences. And these are indications of either a borderline or frankly malignant lesion. So using this data, we can look at color flow and morphology. And in our experience, benign lesions have high impedance relatively, low velocities, peripheral flow, and regularly spaced vessels. Ones that are suspicious for malignancy have low impedance, high velocity, central flow, and clustered vessels. This is a nice table that is used by many people based on a large meta-analysis from Dr. Timmerman and his IOTA group, which is International Ovarian Tumor, Association, where they've pooled all their data, and in this case 1,200 adnexal tumors, and have come up with rules for benign versus malignant determination. And basically, you can see here benign things are unilocular, have very thin internal components, have shadowing, are multilocular, and have very little or no Doppler flow. Malignancies are irregular, have ascites, papillary excrescences, and have irregular multilocular areas and have high color content. Now, using this, sensitivities of 93% and specificities of 90% have been shown. So just by using morphology and color, we have a good idea whether a lesion is benign or malignant. I want to now just change gears and talk about ovarian cancer. It's been shown now that there are basically two types of ovarian cancer. There's ones that are considered slow growing versus rapidly growing, ones that are associated with gene mutations, and have the type 1 lesions have relatively long 5-year survival. In other words, the more slow growing and less aggressive, versus the rapidly growing and more aggressive lesions, and are associated with P53, the tumor suppressive gene. It's also been shown lately that many of the BRCA patients, the patients that have the BRCA mutation, their cancers actually start in the fallopian tube and spread to the ovary. And this, again, is a very interesting development in our understanding of early stages of ovarian cancer. I want to emphasize that it's important to diagnose this disease in its earliest stages. And stage 1 is confined to the ovary with a 5-year survival of 95%. Stage 2 has pelvic extension, still very high survival at 5 years. Unfortunately, many patients, over 3/4 of all patients, present with stage 3 and stage 4 disease, and that is tumors that are metastatic or tumors that have spread beyond the peritoneal cavity. I want to show you a few examples of early stage tumors that we've been able to diagnose with our color Doppler techniques. This is an example where there's an abnormal area in this ovary associated with an abnormal tube, and this was a stage 2 ovarian cancer, and this is the operative picture with the hemostat on the tube, and the low power showing very abnormal vessels. This is a patient that has an ovarian, was undergoing ovulation induction, has 2 mature follicles, but in this area we see a papillary excrescence with a vessel that has very low impedance, and this was a stage 1 ovarian cancer. This is another picture of that same cancer with a blood vessel in a papillary excrescence. This is a patient that shows that the morphologic aspects of the ovary can be helpful with abnormally thickened wall, echogenic areas, and we can see here that the vessels are abnormal and there's low impedance flow, but what is most striking here is the abnormal cluster of vessels adjacent to this mass, and this was a patient that had an ovarian cancer stage 2 that arose in the papillary, in the fimbriated ends of the tube as shown histologically. This is another patient that had a non-palpable lesion but had low impedance, and this was a clear cell carcinoma. This is a patient that has a papillary area within this locule, and as you can see there is blood flow in that papillary area as shown on these low power images. So we can differentiate hemorrhagic lesions that have no flow centrally. We can differentiate hemorrhagic lesions that have this kind of fibrin strands from true cancers by using color Doppler. This is a benign peritoneal cyst. Using these parameters, we were about 98% accurate in negative predictive value, but of course any disease that has low prevalence, the number will be high. But most importantly, we were 83% positive predictive value in our study, as I show you here, and we found 17 cancers in high-risk patients, but luckily 70% of those were early stage. And this has been shown in various studies, some not so accurate, others pretty accurate, but basically color Doppler can be important information added to morphology. So basically, using clinical features and morphology, the role of color Doppler, I think, is very established in finding cancers versus benign lesions. Now, can we do much better? And we hope we can do better extending this in 3D and possibly with the use of contrast. So in 3D, we can look at vessel arrangement, as we see in this image of a functioning corpus luteum on the top and a corpus luteum that is not as well developed. This may improve understanding different flow patterns in ovarian cancer. I mentioned to you that looking at blood flow is very helpful, and we can differentiate clustered and abnormal vessels from their branching patterns as shown here. So 3D in color Doppler can show the difference between, in this case early on, a cyst versus tumor in the other ovary, and of course the tumor had lots of blood vessels. 3D can depict the papillary excrescences in tumors, and we can use this information to look at abnormal blood flow. In this papillary cystadenocarcinoma, we can see an abnormal vessel. And here again on 2 degrees of rotation, we can see in 3D these abnormal vessels. Now this is a cine clip of a metastatic lesion to this ovary, and we can use 3D, and I want to show you a brief cine clip of these central vessels that we can depict on color Doppler as indicative of tumors. This is a patient that on 3D we can identify central vessels. In this case, this was a patient with a high fever and was shown to be a tubo-ovarian abscess. But we can be very accurate in determining the vascular tree using 3D color Doppler techniques. These are some images of 3D color Doppler combined in this case with grayscale in a patient with cancer. We can see the vessels are very irregular and they're clustered. So again, I mentioned the process of angiogenesis. I think it's a central process that we all need to understand. And we all understand that tumors are specific in their flow patterns. But what we really need to be able to see is the capillaries and their flow. And to do this, we really do need these microbubbles. This is an animation showing the microbubble in a vessel capillary, and the microbubbles are intravascular. This is an intravital microscopy showing the level of depiction of these microbubbles. This shows small vessels in the mesentery, and we can see the red blood cells, white blood cells in these very small vessels. And it's amazing to me that the microbubbles allow us to see structures down into the capillary. This is basically the result of many years of research in preclinical models. And this is a picture of the microbubbles. We produce these microbubbles by shaking them up, and the solution first comes in as clear. We shake them for 45 seconds. They are basically perfluorocarbons, and we put the material in a tuberculin syringe. We inject 0.3 cc's followed by 10 cc's of saline, and the microbubbles give a harmonic signal. In this case, we have a picture of a microbubble being exploded by increasing mechanical index. So basically, with the contrast, we basically have a fundamental image of this patient with cancer. Then this is the microbubble image, and we can draw a region of interest and plot the time intensity curve. And this is the wash-in phase as shown here. So this is time to peak. The peak intensity, the area under the curve, and we can calculate the washout phase. The washout phase basically is the vascular volume. And remember that what we're seeing is tumor neovascularity. We're looking at blood flow. This is a picture of a breast cancer using this persistence mode, and we can see that the vessels surrounding this tumor are very haphazard in their orientation. So tumors have these very abnormal areas of vascularity. This is a scanning electron micrograph of some of these microcirculations, differentiating normal hierarchical branching, where you go from an artery to an arterial to a capillary, versus on the right side of the image, the tumor, where there's very abnormal vascularity, and you can imagine that there's increased time to pass through this circulation. Now, tumor angiogenesis, as I mentioned, occurs firstly by breaking through the basement membrane. The microbubbles are intravascular agents, so they reflect the difference between MR contrast, where the contrast goes into the interstitium, versus the microbubbles that stay intravascular. So the potential for targeting abnormal vessels, and in fact treatment, is a very important aspect of microbubbles. Back to clinical assessment of ovarian cancer. There was early reports from this group in Finland that the blood flow can be seen as different in benign versus malignant lesions, and this was using color Doppler techniques. And they showed very early on that tumors shown in red have increased intensity and longer dwell time. This was also shown in a study from France. As I mentioned, the parameters that we're interested in is looking at the washout phase and the area under the curve. We've recently extended this to what's called parametric imaging, so we can show pixel by pixel the peak enhancement, the time to peak, the wash-in, and the area under the curve in this ovarian cancer. Now, the group in Europe combined their different sites and have shown that contrast was very helpful in determining benign from malignant, but had a problem with borderline tumors, and we also have found that. But they feel that pattern recognition is the best way to determine benign versus malignant. This is our study where we first did transvaginal to identify patients suspicious of having cancer. We did color Doppler to look at vascular areas. As I mentioned, we used Definity. We used a 3-minute cine loop, and we quantitated wash-in, peak enhancement, washout, and the area under the curve. Now, to show you what benign looks like in a cine loop, here is a patient that has a cystic mass that had a very abnormal wall here. The bubbles are coming in. This is the harmonic image. As you can see, there's perfusion in the surrounding tissues. Now, when we look at this in a time intensity curve, there's a relatively quick wash in and a relatively quick wash out. This is a 3D image of that first patient that we showed was a benign lesion. Now, this patient, on the other hand, has several mural nodules, and I draw your attention to this area. As you can see, there's a quick wash-in of the contrast, but in this case, as quick as the contrast comes in to the mural nodule, it washes out. And we can see that's reflected in this time activity curve, where there's a quick washout in the cystadenoma. And these are the parametric imaging plots where you see differences in the peak enhancement in the wall and the septum. Now, I draw your attention to this patient. This is a normal-sized ovary with a cystic area in it. Now, watch as the microbubbles come into the tumor. There's tremendous enhancement of this lesion, and this is the time intensity curve showing marked enhancement. This value is very high, and this was a stage 2 ovarian cancer. This is the other ovary in this patient. You can see this one is enlarged, and there's significant enhancement, particularly peripherally in this ovary, in this patient with bilateral adenocarcinoma of the ovary. This is the waveform, the time intensity curve showing significant washout. This is the actual specimen showing on the right ovary the cystic area, and this was a stage 2 ovarian cancer. This patient has an echogenic internal area in her ovary, and on the color Doppler, you could see that it was very echogenic. This is the MR. I thought that one of the possibilities was a dermoid cyst, and I wanted to see if there was fat suppression, which there was not. Here's the color Doppler, the contrast going into this nodule. I want to draw your attention to this nodule, and you'll see eventually that the microbubbles light up in this area. You can see now it's being perfused. This was a borderline mucinous cystadenocarcinoma. And this is an example of a borderline lesion. And as you can see, it has high relative intensity and longer washout. And this is the parametric image showing the nodule. Contrast this with a fibroma. This is a solid lesion that has quick wash-in and wash-out times. as shown here and in the parametrics. Now, we're up to 57 lesions and 12 malignancies. This is our data so far showing difference in the peak enhancement, the difference in the washout time, and the area under the curve. When we apply receiver operating curve statistics, we get data that shows these parameters and showing us that washout and area under the curve seem to be the most accurate in distinguishing benign from malignant lesions. Now, how can we do this without contrast? If we don't have contrast, we know that vascularity of lesion relates to malignancy. This was a lesion that many years ago our chief sonographer at the time noted marked vascularity. This was a peritoneal metastases that histologically has lots of capillaries. So we can quantitate blood flow by using these indices, vascularity flow, vascular flow index, and the difference between benign and malignant is pretty significant. With 3D, we can look at this quantitatively or qualitatively, and basically these are examples that have already been shown. This is a papillary cancer with a feeding vessel. We can do 3D imaging as shown on this loop and look at inside the lesion itself. This was a benign lesion, and these are examples of the raw data of the color Doppler. And this is the power Doppler of that same lesion. Tumor neovascularity, again, has very abnormal branching vessels and clusters of vessels as shown in this 3D cine loop here. I hope you can appreciate this. This is what you're looking at for determining whether it's benign or malignant. This is a typical malignancy with vessels that have different caliper and that are clustered. Now, using these parameters, people have come up with sensitivities and specificities which basically reduce false positives in looking at RI and this is again our data comparing these parameters to the contrasted, and Dr. Lishak's work shows very nicely that contrast is actually more accurate than the vessel quantification patterns. So in conclusion, basically we need to start by looking at the morphology and whether or not there's papillary excrescences, whether the wall is irregular, and obviously whether there's ascites or peritoneal metastases which indicate a malignant lesion. With contrast, there's basically a way of determining benign versus malignant in greater peak enhancement, longer washout, greater vascular volume. At least this is our initial data. We need to expand our series to prove that. Without contrast, we can look at vessels, we can look at the various parameters, VI, FI, and VFI in determining whether something is benign or malignant. I'd like to thank my colleagues, Dr. Lishak, who's done a lot of work, Dr. Andriotti, our chief sonographer, Phil Williams. I would like to also thank our gynecologic oncologist, Dr. Fishman, who has been a very useful collaborator in New York, and many others who have helped us continue this research into this very important topic. Thank you.